speakers, and we have barely, not 35 minutes. I'd like to introduce Dr. Adam Coutts, who's going to speak from here. And Adam has spent the past 5 years between Syria, Lebanon, Jordan, and working as an academic and policy consultant with UNICEF, ILO, ESCWA. And his primary work is on public policy, public health, and welfare issues. He has been working with researchers from Syria, Lebanon, Jordan, and Turkey to examine the growing Syrian refugee crisis. He has been involved in several surveys investigating the cause and consequence of tension between Syrian refugees and their host communities, and assessing the humanitarian response. Dr. Coutts holds a PhD from Cambridge, and he has several postdoctoral research positions at the Harvard School of Public Health and the Department of Politics and International Relations. Since he's going to be next to me, he has only 15 minutes.
Thank you. Thank you to RESCAP-MED for inviting me to speak today. My presentation is slightly different from the one that's advertised in the conference brochure. I decided after yesterday's presentations and actually today's with my team that it may be more useful for me to avoid repeating what's already been said and speak about some of our experiences of conducting research on the Syrian health crisis. In the talk, I will give a number of personal reflections on the humanitarian situation, the response, and the difficulties and opportunities of conducting research. As the saying goes, you need to look back. In order to look to the future, you need to look to understand what has happened in the past. I've also tried to reflect on and link to some of the issues that have been described by presenters yesterday. Just a quick background about myself and colleagues. I've been working with academics and practitioners in Lebanon, Jordan for the past 2 years to look at the humanitarian response, and also to set up health surveys. This involved working with UN agencies, NGOs, and national policymakers. I thought some of the insights from this work may be useful for other researchers here today, especially about thinking how we can approach the post-RESCAP research agenda and also possibly influence the humanitarian response. So, in the presentation, I'll give an overview of the current context and where we are now in terms of the humanitarian situation. I then present a number of reflections on what has happened in the humanitarian response and how academics have reacted or not reacted. Finally, I provide a few possible lines of research and ideas as to how the policy response may be improved, and also how, as researchers, we can contribute to helping the response. I'm sure you're all familiar with the key statistics on the crisis. For instance, we're now 3 years into it, with millions displaced, thousands injured or killed. There's been mass demographic change across the region, with a highly mobile population and fluid border movements. It also seems from our work, when we've been describing situations, and also from the humanitarian community, the situation has gone from emergency to crisis to disaster to catastrophe to cataclysm. But I think probably the best unofficial description given by a UN representative was that it's a big mess. In health terms, there are estimated to be over 200,000 deaths in Syria due to chronic diseases, as well as a variety of communicable diseases and viruses, which were previously eradicated. There are also multiple health systems in Syria which have been created, which has now become a patchwork of provisions set up by the government, the opposition, NGOs. This is also the situation in neighbouring countries, with a combination of private, public, and in some, in Lebanon, Syrian expats providing unofficial medical services. So I think now we can safely say the crisis is in a protracted state. Although given the security situation, which is ever changing in Syria, the response sort of moves between emergency relief and protracted crisis development issues. It has also now become apparent that the crisis has exposed the fragility of pre-existing government services in neighbouring countries such as health and education systems, which I'll speak about a bit later. But as with any major crisis, and such as that of the recent Ebola outbreak, weak systems of governance and accountability have been exposed and become public. Or you can argue that it has both positive and negative effects for the population, also for improving services in the future. The next couple of slides give a quick overview and some thoughts on the state of the humanitarian response over the past few years. Just as a disclaimer, most of these quotes come from UN agencies and individuals we've met whilst doing our research. Firstly, it may be said the response was initially a bit naive and short-sighted. Many people, myself, I interviewed and others in late 2011, early 2012, would often say that they thought the crisis would be over by summer 2012. One could also say that some of the response provided by agencies used a sort of natural disaster type approach, and in some cases actually still does. I think there may have been an underappreciation that this was a conflict and humanitarian situation that was occurring and affecting middle-income communities and populations with consequently different disease profiles, and especially the heavy burden of chronic diseases, high healthcare costs, and high healthcare costs. There also seems to have been an underappreciation of the pre-crisis health behaviours health behaviours and health-seeking behaviours that were dominant in Syria, and the expectations that refugees have of public services. I don't want to give the impression that the UN has not done its job and NGOs don't do any work, which of course is not true. There are major differences, I think, in the last 2 years of how public health academics and those public health practitioners working in the field see the situation. I think maybe we can talk at some point about how to reconcile those differences. The response faces multiple barriers and problems, some of which are listed here. Number one is the continuous lack of funding, which has now resulted in WFP announcing they will cease food distribution if donors do not pay up. The government of Jordan has also recently stopped Syrian refugees from accessing public hospitals. It has also been difficult for agencies to deal with pre-existing state structures and the political maze of the region, which is dominated by vested interests and powerful groups such as syndicates of doctors. Dealing with the political determinants of health has been difficult. In Lebanon, for instance, one of the biggest barriers to health response has been the healthcare system itself and the privatised healthcare industry and associated cost barriers. There are also numerous problems with getting sectors to coordinate and making links between and across themselves, such as health, education, sanitation, cohesion. In that regard, there's been little focus on sort of the social determinants of health in many interventions. For example, in NCD interventions, refugees may receive chronic disease medications, but if you live in a damp, cold, informal settlement with poor sanitation, little food, and no job, any health improvements generated by the intervention are unlikely to be sustained. On more specific aspects of the interventions and gaps, a number of groups have been left out, such as the old, disabled, and adult groups with psychological illnesses and trauma. Until now, the NCD response has been limited due to funding. Treatment conditions like cancer are almost non-existent. And as a number of people pointed out over the last, yesterday and some research I was doing last week, the security situation in neighbouring countries has also prevented interventions from being set up in certain areas. The constant movement of refugees around Lebanon and Jordan has also made it difficult to perform follow-up with patients and to keep reliable With research that I've done with NGOs, health NGOs, a lot have said that it's quite difficult to recruit qualified staff, which has consequently affected the capacity for implementation and also to analyze technical skills to analyze field data. Overall, it seems donors have, or maybe still do, opt for quick fix health interventions to increase their operational visibility. The slow and boring conditions, such as hypertension and diabetes, are low down on the agenda, because acting on these issues takes money and time. And as we saw with my teams from the previous presentations, changing people's attitudes and behaviour change takes time.
5 years.
In relation to academic research, a number of people have pointed out that academics in the region have been suffered from a mild form of amnesia. Across disciplines, people have been slow to consider the implications and impacts of the crisis, despite the fact that there are many previous examples of what might happen in a crisis situation such as Iraq. It could be said that the political terms of health were avoided. In health terms, it could be argued this conference itself could be one of the first times people have actually come together to discuss these issues in the region in terms of humanitarian conflict situations. It's also not really true to say that there is a data gap. There are many studies which have been conducted over the past year. UN agencies have collected tons of data on education, health, vulnerability, in addition to national health information systems. However, in research terms, the situation has arisen where research projects may be actually duplicating each other and covering the same populations. A friend who was conducting research in Oman last week told me a refugee complained that his family had been interviewed 5 times in the past few months, but had seen little change in the situation. Overall, in the past 3 years, there's been very few academic articles, 5 in the last count, I think, on the Syrian refugee crisis. The majority of pieces have been on opinion or media pieces, although health itself in relation to the crisis has come far below issues such as security and ISIS. There are hundreds of NGO rapid assessments, but these vary greatly in terms of methods and data quality. In terms of evidence on the effectiveness or efficacy of interventions across the health sector, there are virtually no studies. A few have begun now with Johns Hopkins. Sorry, just to add one bit, was in funding terms, we perceive that there is little funding in relation to the size of the crisis. I don't think it's all doom and gloom, but in many crises you have sort of opportunities and a silver lining. Again, it could be said that the crisis exposed how fragile systems already were prior to 2011 and how marginalised host communities were. The refugee crisis compounded these problems and now needs addressing for short and long-term gains. Donors in the Ministry of Health have also seen this opportunity. Projects such as the EU's Instrument for Stability project have been set up in Lebanon to strengthen health information systems, the e-warning system with primary healthcare. WHO are also updating the national NCD guidelines and strengthening PHCs throughout Lebanon. But it seems now we need to sort of consider the post-conflict situation and therefore start thinking about how to reform systems, not just to strengthen inertia and vested interests. The example of mental health reform in Lebanon may be a good example to follow. This next presentation will show how these changes and policy reforms require high-level political support and policy sponsorship. Further, when we talk about the development phase, this is not just talking about cash transfers. to refugees in those communities, but it must be a combination and linked to policies such as universal welfare, social protection, and public service reform. Whereas, across the region, there is a need to shift away from expensive high-tech curative interventions, which the region spends a fortune on, and that's sort of an old, sure, an old suggestion. Of course, the big policy issue here is to introduce universal healthcare, which WHO have been promoting for the last few years, but this needs political support in each country in order to tackle the dominance of private healthcare interests and the of doctors. There's also a need, current need, which ESCRO is trying to look at, which is how to pay for policy reform and health reform. As academics usually say, more research needs to be done. However, I think in this case, in the case of Syria, and the impact on neighbouring countries, a lot of research still requires doing in order to help the response and policy makers. I've highlighted a few of the key policy areas, key research areas. Most notably, the crisis could be seen as a large natural public health experiment. Using existing data from the UN and national governments, we can see how the crisis has affected health systems of countries, as well as how government interventions may offset or worsen health. The crisis also provides opportunity for local academics and institutions to lead the research agenda. There has been a sort of tradition to import technical expertise, whereas I think the region does possess enough capacity. Where people do collaborate, local capacities should be strengthened. I mean, RESCAP itself is a good example of how this possibly could work. In relation to research that's ongoing in neighbouring countries and, in Lebanon, there's need to map and audit what sort of research has been done and will be done, sort of the classical four W's of who, what, where, and when. Probably lastly, what are the lessons that can be learned from previous crises, such as Iraq, as Hamid showed yesterday? With Iraq, what should we avoid doing? Iraq does provide quite a good example of how not to do public health in emergency contexts. And as Hamid also showed, NCDs did become the major cause of mortality. I think that's it.
Thank you very much. Thank you very much. We really have, we're 6 minutes late. I'd rather take invite Abdul Rabia to really make his presentation, and then we'll take 2 questions afterwards.